Today's episode of the Gestalt Education Show is brought to you by three of our favorite sponsors: Human Locomotion, Core 360 Belt, and Dynamic Disc Designs. All the information can be found below. By now, you have definitely heard us talk about them, so check out the show notes, click the links, use the codes, and make sure you support our favorite people. As always, we got a great episode lined up for you today, and thanks for tuning in. It's actually even better. I like to get a comment, at least one or two comments on our YouTube page about how the lighting's bad or something else is bad like that. So it keeps everybody on their toes. But we're good. This is perfect. Okay, we're just going to get right into it. All right, everybody, welcome to another episode of the Gestalt Education Show. Today, we are diving into what's becoming one of our favorite topics, and that is the ACL recovery or the ACL rupture. We've had some amazing people on this podcast already talk about it, but we went out and we're thankful for our next guest for agreeing to do this and to sit down with us even late at night here, the one and only Christopher Powers. And so if you are up to date on ACL research, period, you know this name. You've seen it come across your PubMed. And so today we are excited to be sitting down with literally the expert in the world when it comes to the ACL. And so, Brett, you first heard Chris talk where was it?
It was in Chicago. I've been to Chicago the first time years ago. Yeah. And he did a great job. And back then, Chris, you were telling a story about hip abductor weakness, timing, things like that. And the ACL tear. So we thought, we've had Timothy Hewitt and others kind of talk about different ideas on our podcast. And when we talked to you before, we thought that the quadricep might be a good jump off point, because you've done some work there, more work than probably anyone, as far as what the quadriceps doing and prevention of ACL tears. And then even after the repair, some of the asymmetries that we're seeing as we're working these athletes back to sport. And some real interesting things kind of jump out just from looking at the paper you sent us. One is, do you think was the edifice of the paper because maybe we're starting to jog our ACL reconstructions too soon, do you think, in rehab?
I do, actually. So let me step back for a second and kind of give you the background, the impetus behind this.
Yeah.
So, in my clinical practice, we see a lot of ACL patients, and as you probably know, and most of your listeners know, okay, every surgeon has their protocol, right? Okay,
yeah.
Here's the protocol to follow, and these protocols tend to be very time based. Okay, well, at 2 months you do this, and at 4 months you're allowed to do this. Yeah, at 6 months, you're allowed to do that. So, and, I've always struggled with this clinically because, not everybody, but not all patients progress at the same pace. Some are much slower than others. Some move a lot faster than others. So, but we tend to be really dogmatic about these protocols. Okay, well, it's at 4 months, it's time to start jogging. Okay.
Right.
And that's typically what I've seen in the past is, well, okay. And, the patients are antsy to start doing something besides range of motion and quad sets. So they're really anxious to get back to something a little bit more dynamic. And we start them off. But here's the problem. And running is a very quad intensive activity. So when you look at the biomechanics of running, the quadriceps play a very large role in terms of shock attenuation. So when you're hitting the ground at 2 to 3 times your body weight, okay, and you have to attenuate those impact forces, and the knee flexion and the eccentric quad work that occurs is really the key element in terms of cushioning that impact force. And now, if the patient doesn't have sufficient quadricep strength, okay, what's going to happen is they're going to limit their knee flexion. They're not going to bend appropriately because they don't have that eccentric control. And what happens is they hit the ground very stiff. very, very hard, basically. So their mechanics are not ideal. And so that, and so returning someone to run or to jog initially without having a certain level of quad strength can be very detrimental. I think many of your listeners probably have seen this. Well, okay, all right, it's 4 months to start jogging, to start, doing this, because that's what the protocol says. And then they go run for a little bit, and 2 or 3 weeks later, they come back, my knee hurts. My knee's swollen. You know what I mean? And now we have a setback,
Mm-hmm.
So imagine hitting the ground with those forces and not being able to attenuate those forces appropriately. The impact force to the joint is huge. So there's a lot of compressive forces that would occur. If the quadriceps isn't functioning well, the knee is not bending well, what happens is there's a high level of compressive force. And now, that most of these ACL patients have had meniscal repairs or meniscectomy. So their cartilage inside their knee is not ideal. It's not an ideal environment. So now you add in these high compressive loads because the quad isn't functioning, then now we have another problem.
Yeah.
Now you got a swollen knee, the quad gets inhibited, and now we're stepping back instead of stepping forward. And so that was really the main impetus behind this paper, was to, let's look at the relationship between quad strength symmetry
Mm-hmm.
and running symmetry based on the ground reaction force values, and try to establish, is there a cutoff by which we can predict who is going to be asymmetrical in their loading and who would not. So, and really to kind of take away the time component and really try to put some objective numbers to this. How strong should your quad be relative to your uninvolved side before you start the jogging protocol? And that's the question that we wanted to address.
Beautiful. And I think what was interesting about this paper too is, like you said, you actually did measure at different percentages. And so can you kind of talk us through like what the actual conclusions for that study was what percentage was your best perceived symmetry, and what are the consequences mainly? I know you kind of talked about that, but the consequences long-term of not having that symmetry in the quadriceps.
Yeah. So we know, so it's been suspected that loading asymmetry in these patients persists for years. So this has been well documented that, during squatting, walking, running, there's this learned behavior of compensation, basically. So, and I think this happens during the rehab process, first month or two after reconstruction, they're hobbling around, they're putting all their weight on the other side. This becomes a learned behavior, and it carries over to all activities: walking, squatting, running. And so now we've created this new motor pattern that is very asymmetrical. Now that asymmetrical pattern is thought to perhaps be contributory to 2 major long-term problems. Number one, this early onset osteoarthritis that these patients have. And 2, re-injury, and maybe contralateral re-injuries. So, it's suspected that this asymmetry is detrimental in the long run. So that is a big part of the rehab process, is to restore quadriceps symmetry and loading symmetry in these patients. So here's the idea. If I start running and my quad strength asymmetry is off, and now my running asymmetry is off because of it, that now becomes a learned pattern. You know what I mean? And that has been shown to stick for years, 2 to 3 years post return to sport. And I think that's a problem. Yeah. So basically our finding was the cutoff turned out 88%. So patients who had quad deficits less than So let's say a 12% deficit. So greater than 12% deficit had a high probability of, significant probability of being asymmetrical in the running.
Right. And that was measured through ground reactive forces during the actual running cycle.
Correct.
Yeah.
So we measured the ground reaction forces during running, and then we have their quad strength values on both sides. So we create a quad strength symmetry value and then a running symmetry value.
Beautiful.
So, and 88%, that seems a little high. When we looked at existing literature, some people say, well, it's okay to start running at, 60, 75%, 80% quad symmetry. And it's all over the board in terms of the recommendations. So what we reported was much higher than what's currently standard.
Yeah, right. Yeah.
So what this tells me as a clinician is like, look, I don't let my patients run until we get our quad strength to 88, 90%. And that may mean we hold them off until it's 6 months.
Right.
To me, that's okay. There's no harm in that. I mean, it doesn't, I don't think it gets people back to sport quicker.
Right.
If we're operating off a 9-month to 12-month time period, which seems to be the norm these days, there's no huge rush to start running at 4 months.
Right.
And I think you run the risk of, okay, now I got a tendonitis, my knee is swelled up a little bit. That impact force is too much for the knee at that point in time. Now we have a setback. And
right.
You know how that goes.
Yeah, exactly.
And then how important is the distinction between open and closed chain function, as far as like in physical therapy, we have a lot of measurement of quad strength in an open chain fashion, but obviously running's a closed chain event. So how important is it that we kind of bridge the gap between those two different distinct functions, open and closed chain function?
Yeah, but so in our study, we quantify quad strength open chain. So on a dynamometer. So that is our standard way of assessing quad strength. But you're right. I mean, obviously during running, it's all muscle groups are working together. But in my opinion, when I'm training quadricep strength, we use a combination of open and closed chain because I think it is important to isolate. And one of the problems is if you just stick solely with closed chain exercises as a rehab tool, these patients compensate. There's intralimb and within limb compensation and between limb compensations. And work that we're doing here at USC, this is more Susan Sigwart's work, is showing that you can't visualize it. It's so subtle that clinicians can't really even see it kinematically. So the problem is these patients they can cheat, and you think they look symmetrical when they're squatting, but they're really not.
Right.
So I think using a combination of isolated work and closed chain, I think, is really the key.
And yeah, I think that's well said. And I notice you're very careful to refer to the whole muscle as a quadricep. There's obviously been people have just basically been enamored with muscles like the vastus medialis oblique. Can you speak of, is that distinction important, or is that kind of just minutia that doesn't really matter at this stage in the rehab, or doesn't matter at all? Or what's your opinion on all the attention that's been given to the vastus medialis portion of the quadricep?
Oh boy, now you're going back 30 years.
That's a dark, lonely road, isn't it?
Yeah, look, this was the big issue with patellofemoral pain. So this is my other area. And, back in the 80s, we were all trying to strengthen the VMO with the idea that we were going to stabilize the patella and pull it more medially, et cetera. But to be honest with you, that whole VMO dynamic instability theory, VMO versus vastus lateralis, has really been, I won't say disproven, but it has fallen by the wayside due to lack of evidence. So in my opinion, I look at the quadriceps as an entire unit and not trying to really isolate one aspect over the other. There's really no evidence. A, we can selectively strengthen one component over there. There's absolutely no evidence for that. And B, we only, in quad atrophy, when we see post-op or whatever, it tends to be systematic across all the heads of the quadriceps. So there is no selective atrophy, if you will, of the vastus medialis. So, the basic tenets of that theory really don't pan out from a research standpoint.
Perfect.
So, in my opinion, but, so we just look, you attack the quadriceps as a unit and not try to be that specific about it.
Beautiful. What about in the testing? If let's just put it to our clinicians here, or for us, is just a regular dynamometer a good option for testing quad strength? Do you have specific standards that you'd like clinicians to maybe be up to date on with that type of testing, or can you give us some resources on clinical practice for measuring those?
Yeah, I mean, also we're using a HUMAC norm, a dynamometer. So. That is obviously a big, expensive piece of equipment that's not readily available.
Yeah.
I know a lot of clinicians who use handheld dynamometers and tensiometers. There's definitely some lower cost options out there. There are some problems with those, obviously, in terms of stability and reducibility, reliability and that sort of thing, but I think it gives clinicians a gauge.
Sure.
We need something. Manual muscle testing, forget it. It's worthless when it comes to the quadriceps. So I think that's not even in the picture. But, if you have a handheld dynamometer and you have a strap, you have something fixed that they can push it against, it gives you a rough idea. Now, it won't be the same level as one of these big dynamometers, but I think this is a big problem. I'm a big believer of technology, and I think we really need to be more objective in our clinical decision making. And to me, this is important.
Right.
Use this as a criteria to progress someone in the return to sport phase of the program. And if I didn't have those numbers, I'd be guessing.
Right.
Okay, great. I've been doing this for a long time, so maybe 75% of the time I guess it right. And the other 25% I guess it wrong. And those 25% don't end up being very happy in that case.
Could you speak of the correlation between quadricep girth and girth measurements in strength? Because there's been kind of a push the last couple of years that I think it's like the BFR movement that is basically making everyone kind of pay attention to what we've all seen after the ACL injury, where we see a lot of atrophy in the quadriceps. So is it important to be measuring girth? Do you think that's like an important metric or objective metric that we should be looking at? And what's your opinion on that?
Okay. Yeah, I want to talk about the BFR thing as well. So
yeah, cool.
Girth, no, I've seen this a lot, and I see a lot of these patients for testing, and I see the girth differences many times, but I don't see the strength differences. So I don't think girth is a good indicator of strength. And I think a lot of patients don't have the girth, but they have the good strength, surprisingly. Don't ask me why, because I haven't figured that out yet. Because it looks smaller, but you test it, and I go, yes, man, it's just as strong. So I don't understand that, but I have seen it quite a bit. So I wouldn't rely on girth as an indicator. The BFR thing, I have a couple strong opinions about this. I think BFR is a great tool initially. When I say initially, I'm talking the first month post-op. And I think the role of BFR is really to reactivate the quadriceps, to get the quadriceps going, to really, the knee can't handle large loads at that point. We can get a good muscle, response with low load. I think it's great. But at some point, you got to get off of it. And I've seen too many clinicians be doing BFR for 4, 5, 6 months. And at some point, you have to start loading the muscle tendon unit. And that muscle tendon unit needs load to adapt to handle the loading that's going to happen during running, jumping, cutting, and that sort of thing. But if you're doing all your strengthening with very low loads, the tendon is not going to adapt to the loads that are required during sport activity. And then you're on BFR too long, and then you go right to more sport loading, then the tendon becomes overloaded. Now you got the dreaded quad tendon problem.
Yeah.
And which is all too common in the rehab world. And my thought is we progress patients too fast into the higher demand activities when they don't have the adequate quad strength and tendon adaptation required to handle those loads. Mm-hmm. So I personally put a lot of this post-op tendonitis problem in these patients on us in terms of progressing patients too fast when the muscle tendon unit's not ready for it. I think we need to slow it down.
Right. There's a little bit of evidence too to show that if there's a fusion in the joint, that there can be some inhibition in the quadricep. So obviously we all deal with, swelling with the post ACL rehab program. Do you worry about that, or is that just, is that on your radar?
Oh, 100%. Yeah, that's one of the number one priorities post-op is working on that. But I want to go back to what I started with. You start running on a weak quad, the impact forces on the joint go way up. The cartilage is not normal. The knee becomes swollen and low-grade effusion in the knee. And that shuts down the quadriceps. And that just reverses everything you've been working on. So that's one of the downsides of starting jogging too early. Mm-hmm. Is that, the high impact forces on damaged cartilage, no good shock absorption from the muscle, the knee gets hammered basically. And right. That creates a low grade inflammation and, that shuts down the quadriceps. Now we're back 2 months. Mm-hmm.
Mm-hmm. So. What about the testing? I know that we kind of talked about differentiation of the different quad muscles. Talk us through what your perfect world of that testing looks like, open chain, knee extension. Like what, is it just pure sagittal plane? Is there any credence to creating internal external rotation, different hip positions, anything like that? Or is it just good to standardize it in the sagittal plane?
Yeah, we just standardize it in sagittal plane. We test, really most of the research that's been done on ACL is mostly isometric strength testing. Mm-hmm. We tested 60 degrees. And yeah, it's just an indicator of muscle performance. I'm not saying it has to mirror the demands during running or whatever. That's not the point. It's like, okay, here's a standard to compare limbs. Mm-hmm. Right? Is your involved limb up to speed to your uninvolved limb?
I guess maybe a better question would be, what would your standard test be? Can you walk us through that maybe just a little bit? Like, I know you just said sagittal plane, but when you're testing a patient for limb symmetry, what would be your perfect, ideal standard?
Okay. So let me walk you through our strength. So we measure quad strength. Mm-hmm. Now I'm going to be a little controversial here. What we don't measure is knee flexion strength.
Okay.
I had to explain this. This is a little.
Yeah.
So let me ask you guys, what are the function of the hamstrings during running or jumping or cutting? How do the hamstrings function in weight bearing during sport specific activities? What's their role?
We think of the hamstrings kind of like the reins on of a horse to be able to control internal and external tibial rotation. We distinguish the difference between open and closed chain function as far as which way the muscle's actually pulling. We don't really think of an origin insertion as much as we think of attachment sites depending on open and closed chain function. So I don't know.
Yeah. So you're right. So During weight bearing, hamstrings, they cross two joints,
Right.
hip extensors and knee flexors.
Mm-hmm.
In weight bearing, they're functioning as hip extensors.
Right.
Largely. Yeah. And now, of course, they're stabilizing the knee and
Sure.
doing all the things you just described. So here's my thought on this is really, for me, what I want in terms of symmetry is really, I want the quad strength to be equal to the hip extension strength. Hip extension, we also test hip extension strength, which is really glute and hamstring.
Mm-hmm.
So I'm looking at the symmetry between the hip and knee extensors as kind of my gold standard, as opposed to open chain knee extension versus knee flexion.
Got it.
Because that is not how the hamstrings function when you're cutting, landing from a jump, running. It's not an open chain scenario. So really, when I assess hamstring strength, I'm doing it through hip extension. And we have published several papers showing that the knee extension, hip extension strength ratio. So I look at the quad strength versus the hip extension strength. Does that make sense?
Oh yeah, absolutely.
Yeah. That's a really good way to look at it.
And I want that ratio to be close to 1. And a lot of athletes, their quads are twice as strong as their hip extensors.
Mm-hmm.
And now you got weak hip muscles, where that goes.
Yeah. Well, that kind of goes back to our conversation with Tim Hewitt on quad dominant versus hip dominant versus trunk dominant, those types of things. Yeah.
Exactly. You're quad dominant. But when you test people that move in a quad dominant way, which we know is not ideal, their quads are much stronger than their hip. Why are they not hip dominant? Well, because their power and strength is in the quad relative to their hip extensors.
Yeah.
So really, I look at that symmetry as being a really critical aspect of return to sport, because you got to have the hip strength.
Yeah.
You got to get the quad strength back. But what you don't want is intra-limb asymmetry, where the quads are twice as strong as the hip. That's a problem, because that we have papers showing that people that have more quad strength relative to their hip, they absorb impact more through their knee relative to their hip.
Well, and if hearing you talk, that it sounds like obviously you've talked about the quad a ton in your research and things like that, but training the quad and the hip at the same time probably makes a lot of sense, especially in these return to play and those types of things.
Well, think about this. So
sorry to interrupt this episode, guys. Hope you're enjoying it. Real quick, we have an amazing opportunity. The DNS World Congress is coming to Chesterfield, Missouri this June 14th through the 16th, 2024. If you guys attended our NDS or our Neurodynamics Congress, you know that this is something that's very close to Brett and I's heart, something that we are going to keep doing and keep doing and keep doing. So this year's Congress is all about DNS, dynamic neuromuscular stabilization. This is literally like looking into the ocean, as Brett says. This is the lens that we look through each and every one of our patients with. And this is going to be an amazing opportunity because Pavel is back in town. So the originator, the creator of DNS, Pavel Kolaj, is coming to the States for the first time in 5 or 6 years. I don't even know how long it's been. He's bringing along with him Elena Kobasova, which is literally the backbone of DNS. She's one of the most underrated neurologists in the world. So we're super excited to hear from her. Marcela Safarova, if you haven't heard her speak, she is literally the queen of pediatrics and musculoskeletal health. We also are going to have almost every single U.S. instructor at the Congress who's going to be speaking. It's going to include demos, lectures, hands-on. We're going to have, as always, a get-together afterwards with your chance to talk to these guys face-to-face and have a couple drinks with them. This is going to be a great opportunity. It's a great price too, especially for students. It's only $4.99. So be sure to use the code DNS student to get your discount on that. For more information, or if you have questions, go to gestaltedu.com/DNS-Congress. Thanks for tuning in, guys. Enjoy the rest of the episode.
Let's go back to what are the risk factors for ACL injury to begin with? Valgus, knee dominance, knee valgus, hip weakness. We have a paper showing that hip weakness predicts future ACL injury. So imagine that. So you have a patient who has a non-contact ACL injury, probably has a lot of hip impairments and valgus and all the things that we talk about. They have a reconstruction. They go through rehab. The rehab largely focuses on getting the quadriceps back, which is great. No problem with that.
Right.
But they're ignoring the fact that they probably had pre-existing hip deficits
in the first place.
And now they return them to play. now they still have the same risk factors that caused the initial injury going into return to play. And hence our re-injury rates are 30%.
Right.
Which is not acceptable.
And then in your paper, you reference Webster and Hewitt's paper about how the trajectory of the ACL repaired knee isn't great from a degenerative standpoint. So do you think that paying attention to everything that we just talked about will change the trajectory of how the knee is aging? Or do you just feel like, once you've torn your ACL, your knees, we're going to have more osteoarthritis in that knee as your life goes on? Or do you feel like the interventions that you've been doing will actually be changing that?
That's a great question. And to be honest with you, we don't know, because those longitudinal studies have not been done. But here's the deal. Not every single patient who has an ACL reconstruction goes on to early onset OA. So it's a percent, it's about 40%. So now that's a big number, but not every single patient will progress to that early onset situation. That's what the literature tells us. So some patients are escaping it somehow. And maybe it is because their mechanics have been optimized to reduce knee loading. You have to think about what causes knee OA. It's abnormal loading to the joint. So we have to, as physical therapists, we have to make sure that the joint loading is optimized, meaning that the mechanics are sound so that they're not putting undue load through their knees. And that's something that we really have to take a little bit more seriously as a profession. And because right now it's largely, okay, let's get strong and let's do some hop tests. Okay, 90%, great, you're good to go. It's 9 months, and we're not really looking at the big picture here. And we're not looking at the quality of the movement. We're just progressing patients based on the timeline, regardless of their capabilities and capacity. And we don't have really good return to sport criteria.
Not that timelines are important, but we had Dr. James Andrews on our podcast, and he's on record for saying, he said he wants his athletes, if it's possible, to wait a year to return back to sport. So although we're kind of against timelines, as we've talked about, have you noticed the same thing? I mean, do you think like a 1 year might be a good goal to make the athlete, if the sport allows? And I know there's scholarships and a lot of things that are involved, but if we can make them stay out a year, do you think that's maybe something we should be doing?
Well, the data do say that the longer you wait, the better the outcome.
Right.
But the question is, what are you doing during that year? So I would argue, if you're getting really bad rehab for a year, I would take great rehab for 9 months over crappy rehab for a year, to be honest with you. So I think it really depends how you use that year. And if you really are using that year to optimize strength, power, mechanics, everything, then I think it's a great, smart. But we're returning people before they're ready, before we're accepting, okay, well, they're 90%. That's good enough. Well, you have to remember, these ACL patients had pre-existing risk factors. That's why they're ACL patients. So in my book, we spend the first 6 months correcting the post-surgical impairments that are caused by the injury and the surgery. And then we switch focus to, okay, what were the pre-existing impairments that got them here in the first place? And that's the second half. And that may be another 3 months or 6 months. And that's where we get heavy into the hip stuff and changing switch strategies and hip power and normalizing these hip to knee strength ratios. So, but I think it's great. The year is great if you use it wisely.
Right. It's a good message to put out there too. I mean, I think that is the key. I mean, I think, we talk about chronic pain sometimes on this podcast, and, you can get to chronic pain because you get shitty treatment, or you can get to chronic pain for all sorts of other reasons too. But I think, the re-tear rates, it's impossible to probably study how good the rehab is versus how the time frame, it's just like an impossible thing to postularize. And so I think that's it's a good message to put out there that the rehab matters.
It does. It's the key.
Yeah.
Since we got the guy here, I'm dying to ask, what is your opinion on, there's been now everybody's talking about quad tendon. Obviously we've had patellar tendon, you got hamstring tendon,
autograft.
Yeah. What is your, since you're in the world and you're the person in the world on this, what's your take on that?
What if you tore your ACL tomorrow? Which one are you doing? That's what we want to know.
Oh man, okay, that's a good. I think about that all the time, actually.
Because then you'd really be under the microscope, wouldn't you?
Yeah, here's what I've seen and read, and we've have a paper on this as well. So what I'm seeing a lot here in LA, a lot of quad tendon grafts. Surgeons like the quad tendon because it's a big, thick graft. It's meaty. And I think initially I thought, well, we're not going to mess with the patellar tendon because that's where all the pain goes. You know what I mean?
Right.
So what I've seen though, and I don't know if this is a good thing or a bad thing, the quad atrophy and the time it takes to get the quad back with a quad tendon autograft is much longer. It's patients have a harder. There's a greater inhibitory effect on the quad muscle itself. Now, maybe because it's closer, who knows why, but I've seen that, and we have a paper that we published on it, and there was a recent paper I just read that found a very similar thing. So the time it takes to get quad symmetry back with a quad tendon graft is longer. Now, maybe that's a good thing because that keeps them in rehab longer. I don't know. But that is now, what was the question? So
which graft would you choose? Which graft? Patellar, quad, hamstring?
I would not do hamstring. I'm not a surgeon, so I'm speaking way out of my league here. But I'm not a big fan of taking a muscle away. Do the hamstring grafts stretch out over time? I don't know. I would either do quad tendon or patellar tendon. Which one would I take? I don't know. I would have to really think about that. But it'd be one of the two. Definitely not an allograft.
Yeah.
I'm 60, and I know they tend to do allografts for older patients like myself, but I would not do an allograft.
Well, that's kind of the consensus. Even, we've had some awesome surgeons, George Paletta, James Andrews. They're all kind of a little bit mixed, maybe 50-50. I'd say Kremchek, Dr. Kremchek we've had on, and versus patellar versus quad. But it seems like hamstring has kind of gone to the wayside. And I think that I can't remember who talked about it. Is there any difference in knee OA long-term between the grafts? Is that a correlation? Do you think that that's reasonable to consider when you're choosing a graft, or is that more understanding what we've already talked about in this podcast with quad dominance, things like that?
Yeah, I'm not aware of any research that's looked at that graft type, but my guess would be that the status of the meniscus in the cartilage matters a lot. So if you have a meniscectomy with the ACL reconstruction, that opens the door. I mean, we know that meniscectomies go on to early onset OA. So, and I think loading of the knee throughout the return to sport phase and beyond is really a key factor as well. So you combine abnormal loading with poor cartilage health, you got the recipe for early onset OA.
Yeah.
I think that can occur irregardless of the graft type.
Fair.
There's kind of been a movement now of especially like the older patient who tears their ACL to not have the repair done. And obviously that knee gets a lot of arthritis as it age. What do you think about this movement in the younger athletes who have like an ACL injury in isolation, not getting it repaired, and what that athlete's career looks like after that? There's been a couple famous cases of that like happening, and they'd obviously have to be great copers or adapters. But what's your opinion on that?
Oof, boy, I just don't see. where I am in my practice, we just don't see those patients. I don't have a lot of experience with non-reconstructed knees.
Right.
Yeah.
So I don't have a good gauge in terms of, if I tore my ACL, I would have it reconstructed.
Yeah. I think we're all on the same page there.
Because I don't want to go skiing next year and turn and my knee goes out. Now I've torn my MCL and now I've damaged my cartilage even more. I don't know. I would have the reconstruction and rehab myself perfectly, and then
it'd be perfect,
and then hope for the best.
Well, I think it's just like everything. The pendulum has swung so far, and they get the cross bracing and all this other thing. And at the end of the day, I think it all comes back to what we've talked about this whole thing. It probably depends on the goals of the patient and things like that. But I personally don't see a patient that would benefit from just taking a year off and rehabbing without having that ligament in their body. And so just biomechanically, it just doesn't really make sense to me. But that's my personal opinion. So,
well, you could probably, if you're just a straight ahead athlete, a runner, jogger, and you weren't doing skiing or soccer or basketball, you may be able to get away from it, but I don't know. Not for a young athlete.
Yeah,
I don't know.
I agree.
And then if you were looking at if you were making a pie chart, Chris, and we were talking about what are the most important things that need to be considered when we're rehabbing after an ACL reconstruction? We've talked about quad strength. We talked about hip strength. We talked a little bit about hamstring. Obviously, there's been a little bit out there on Q angle. There's a hormonal influence. There's obviously a female-male component. Could you kind of break down what that pie chart would look like in your world as far as like the most important thing, and then kind of work backwards from there?
Yeah, I mean, obviously, we can only address the things that were hormones, Q angle. Those are things we can't change. So we'll put those aside. But I look at it in three key things. Number one, recover from the surgery and the injury. Restore your quad, the muscle strength around the knee. Okay, that goes away after the reconstruction. Quad, hamstring, and calf. By the way, we haven't talked about calf strength, but super important. Okay.
We can get on that next.
Recover, the second piece of the pie. And I don't know which one's more important, but the second one is address pre-existing risk factors. And that goes to the hip abductor strength, hip extensor strength. Those strength deficits that we kind of forget about. The third piece of the pie is really working on the movement piece and really working on correcting core mechanics, trying to get people to be more hip biased in their movement, not knee biased, trying to prevent dynamic knee valgus, absorbing impact properly, using your hips and knees, not just your knees. So I look at it as a 3-part process, and now which of those is most important? I don't know, but I do know that working on the movement piece is super important because I think that's what gets the athlete in trouble in the first place. So putting someone back out with the same set of risk factors that caused the initial injury is bound to come back to bite you. And that is really the movement patterns, the biomechanics, as well as, I think, the hip component of it.
Well, I think you just labeled, instead of using timelines, you use 3 distinct sections. You have to pass each section before you go on to the next one. I think that makes a lot of sense when you're designing a rehab program for ACL.
Well, we do the hip and the quad stuff together in the first 6 months. But yeah, I think that's really critical. And we spend a good 3 months just working on movement retraining and cutting and making sure their mechanics are good. And that's, I think, the big missing piece that gets missed in a lot of. I think we do a reasonable job with the strengthening, but not necessarily looking at the movement side of things. Because
is it worth? Go. I'm sorry.
There's just a lot of research showing that certain movement patterns are predictive of future injury.
Yeah.
There's prospective studies out there. Tim Hewitt published the first one, but there's been 5 others that have been published since Tim's paper that show different biomechanical predictors of injury.
Is
Mark
it worth,
Paterno's looked at this for re-injury as well.
Cool.
is it worth looking at trunk position? Obviously, when we look at patients tearing their ACLs when no one else is around them, you see their center of gravity is well outside of their base of support, that being their feet. It's kind of an intriguing topic, but I feel like sometimes like that's a hard thing to coach, like in sports. Is it? Because, in the past, people have talked about like core strength and stuff, but just because you have a strong core doesn't mean that you know where your rib cage is relevant to your landing position and jumping. I guess what I want to say is it worth going after or not necessarily?
The trunk stuff?
Yeah, the trunk positioning.
Yeah, I mean, I think, to be honest with you, a lot of trunk positioning has to do with hip strength. So if I have a weak hip abductor, you know where you're positioning your trunk, and you compensate. So I think it is important. But you're right. We cannot correct and reduce all movement pattern. You know what I mean? If you land awkwardly under the basket and your arm is reaching out, and we can't prevent that from happening. The analogy I use is, you wear a seatbelt when you're driving your car, hopefully. And just because you wear a seatbelt doesn't mean you can't have a major injury or get killed, right? Now, wearing the seatbelt reduces the risk of a major injury. It doesn't eliminate it.
Sure.
And all we're trying to do in PT is put seatbelts on these athletes. So in a majority of situations that they get in, they can get out of it. But they get in a really tricky situation. I mean, we can't prevent that.
Yeah.
So, but I think core strength, hip strength, I think it's all important.
And then I know you're going to know who Gary Gray is. We've had Gary Gray on our podcast, and if he was on here, he would say that we actually probably need to be training our athletes into some of these valgosity positions, because once they get out in the field, they're gonna get themselves into that position. And this is just like a philosophical debate that rages on between all different camps. So what do you think in kind of Gary's model? Do you think it's important that we eccentrically control the knee into maybe a bad valgus position because they're potentially going to be there? Or is that not an important thing? Or let's not even go there because it's late and we've had a long day?
All right. Well, I don't believe in it. I would not do. I don't do it. And here's my argument. When we talk about dynamic valgus, for example, so if my hip abductor is functioning eccentrically, I have a problem. We want a stable pelvis and a stable hip. And really the role of the abductor is more isometric. But if I go into a lot of valgus and there's a lot of eccentric load, that's a problem. So I really, gluteus medius and the hip abductors should be more stability. No. So I don't train it eccentrically because that's not what I want. If I have an athlete going into a lot of eccentric hip abductor, they're in trouble.
Right.
And that typically means they don't have the stability of their hip to control it. So I just, I don't personally follow that approach. But
yeah, that's a good answer.
Good answer.
That's just me. But
yep.
Yeah.
Oh, yeah. I think that there's a middle ground. I think we're probably somewhere in the middle between each of you. That's the hard part. I think with all this is it all comes down to clinical experience. But what I forgot to mention is you are obviously with USC, and I'm sure you've got a bunch of amazing research studies going on right now. Can you just kind of give us a little bit of a glimpse into the future of what's going to be coming out with your name on it, and kind of what are your big projects right now, and that kind of thing?
Yeah, right now we're definitely focused on the ACL. We're really interested right now in re-injury and we're really working on developing a movement screen. Basically, it's basically a return to sport assessment, looking at movement quality in terms of identifying some of these pre-existing risk factors. So that's a big thing we're working on right now. I'm also really interested right now in looking at this interaction between anatomy and biomechanics. So I think a lot of these patients, There are, we know that there are biomechanical risk factors for ACL injury, but there are also well-known anatomical risk factors for ACL injury.
Like an inverted hip or like?
Well, like tibial slope.
Oh, yeah.
Intercondylar notch. No, just related to the knee itself. And what really is interesting to me is really when you combine faulty biomechanics on imperfect anatomy, you got the perfect storm. And really trying to better understand this comprehensive view on risk factors for ACL injury. And because I think you could, if you have poor biomechanics, you're not doomed for ACL injury, but as long as you have good anatomy underneath the hood, But anyways, that's something I'm really interested in. Not that we can correct anatomy, but just from an academic standpoint, really, because some of these patients that we have trained that gone through our program that have great mechanics, that have great hip strength, and some of them do re-injure. And I just scratch my head going, holy crap, what did we miss here?
Right.
And so, it's not perfect. Now hopefully we've reduced the rate, but we haven't eliminated it. So I'm just really interested in understanding why some of these patients have 2 or 3 ACL injuries. What are we missing here?
Have you been able to identify ways of? We're always bringing it back clinically. Ways of identifying anatomy that could be a red flag as someone that's doing a pre-participation screen or something like that. I mean, is there anything out there, or is it just imaging is your only option?
Right now, imaging is the measurements we're taking only can be seen imaging wise.
And specific imaging, I'm sure too.
MRI.
Yeah.
Yep. So all there's a ton of research out there with anatomical risk factors. It's not in our field. It's more the orthopedic surgeons are well aware of it, but we're less aware of it because we don't know it. We don't see it.
Right.
We can't fix it. So we ignore it.
That's right.
But imagine if you had a patient come in your clinic and they had this constellation of anatomical risk factors. And you would go, okay, I got to be on my A game on the biomechanics side.
Right.
So, anyway.
Which would be buy-in for our patients to get our
treatment, with their exercises or
absolutely to follow through with care and things like that. I think if you can figure that out, holy smokes.
So if you have risk factors for diabetes or whatever, or heart disease or cancer or whatever, what do the physicians tell you? You have to make some lifestyle changes.
Right.
Stop smoking, eat better, exercise. You're at risk. And you have to minimize that risk. So if patients knew they had inherent risk for certain injuries, say, look, as physical therapists, look, you got to be on a good program here to prevent knee pain or knee injury or whatever. So, medicine does it. They have all the risk factors for all these injuries or all these medical conditions, but we could be doing the same thing, So anyways.
As we wrap it up, you kind of hinted on the gastroc, and I know there's some research on the soleus too that Tom Michaud has exposed. What do you, without going all the way down that lonely road, what are you finding with those muscles? And do you think that might be maybe the next 5 years of ACL research, so looking at the muscles below the knee actually, or that are crossing the knee, like the gastroc and maybe the soleus or tibialis posterior, which one you were talking about?
Yeah, so 100%. So, when you have a weak calf, gastroc, soleus, and as well as the perimalleolar muscles, you tend to collapse into excessive dorsiflexion, which puts you in a knee bias position. So if your tibia collapses forward and your knee shoots forward to your toe, your quad has to work harder. So basically, I think calf weakness can lead into what we have termed as this quad dominant pattern. That, and looking at people that have weak calves overuse their quads. And we're doing a study right now, a doctoral student who's looking at the relationship of calf strength and knee loading in runners. This is not an ACL project, but basic finding is the more tibial collapse forward you have, the more dorsiflexion you have, the greater the knee loading. And then that's related to calf strength. So I think there is implications here for, ACL injury. Because, there's been some notable ACL reconstructed athletes that have torn their Achilles tendon. You probably know a couple of them. And so I think that I look at that and go, oh man, maybe we've been missing something over the years. So we test calf strength and we have added that into our protocol. I think it's important to stabilize it. It's a stabilizer of the knee.
Yeah.
Why not?
Yeah. Well, I think to your credit, you're revolutionizing the research, and thank you for your contributions, number one. And I think we're kind of homers for Thomas Shode's gadgets and his dynamometers. He's got some great ones, honestly, his site, humanlocomotion.com, that are pretty accurate as we've seen as far as testing when it comes to foot strength, and then also you can use it for the quad and the glute too, which would be amazing, the hip extension. But just to close, I mean, me personally, I just thank you, Chris, for your research, for your efforts for this. It's a problem that needs to be discussed more because it's happening more and more and more. And I think, as someone that's in the trenches on the high school athletes, this is something that I hate to see. And it seems like I'm seeing it more. And so the more we can do to, one, figure out risk factors to your point there, and then two, to make sure that when we're returning these people back to play, that we're not just using timelines. I think that that's a great message to put across, that if your assessments and your objective data isn't corroborating with the timeline, be able to tell the orthopedic surgeon this and be like, hey, they are not ready. I know you want to clear them, and I know the mom and dad and the coach and everybody else wants to, but they're not ready. Plain and simple. And I think that that's a drum that we need to continue to beat. So
I think too, I mean, your paper exposed that we're potentially jogging and running our ACL reconstructed athletes too soon. I mean, I think that your paper obviously filled that void, and that's probably understated. I think that hopefully now more people will pay attention to the paper that we presented tonight. So
which I'll put in the links and a direct link to it so that you can read through it. So
contact for him.
Yeah. So Chris, I mean, what if people want to, number one, if they want to read more of your research, obviously PubMed's a great resource, but where can people find your work, number one, and reach out to you? Maybe if they have questions or, work with you, all those types of things.
Yeah. I mean, obviously my USC contact, you can find that online. My clinic, Movement Performance Institute. I opened a clinical facility 15 years ago. I don't know if anyone even knows this, but we do a lot of return to sport testing and a lot of assessments, and it's a state-of-the-art PT clinic. We had cameras, force plates, and the whole deal. So movementpi.com is the clinic website. At movementpi, you follow us on Instagram. And yeah, I mean, like PubMed is probably the best place to look at research and stuff. And or you can just email me. I'm happy to send you papers.
Yeah, beautiful.
When's the book coming out? I know,
dude. That's on my list.
All right.
So before I retire, I have to write a book.
You have to.
Yeah, we would love that.
I know, but
so Chris, I mean, we love your work. We obviously love everything that you've done, and you just have to promise. Now that you're a one-time guest, you're a second-time guest. We're going to come to USC, and we want to see your lab and everything like that. We'd love to see your clinic and give people a first-hand look at that. But again, thank you for sitting down with us, and thank you for contributions, man.
Yeah, great job, you guys. It was fun.
Yeah, beautiful. All right, guys. Well,
thanks, Chris.
Yeah, good luck with patients, and we'll see you next time, guys. All right.
Great.
I hope you enjoyed this episode of the Gestalt Education Show. If you liked it, share it, subscribe to it, send it to your friends, send it to someone that needs to hear this message. We really want everyone to be able to tune in and get the best clinical advice that they can, which we're hoping that we're giving to you with these special guests. So if you have any questions, please feel free to reach out to us, or if you have any suggestions on upcoming conversations, let us know. For a list of our upcoming courses, we're adding them all the dang time. So go to gestaltedu.com, click on courses, and they'll all be right there for you. All right, have a good day.